All right. So thank you to everyone who's joined us today. This is the Center for Optimizing Rural Health kickoff webinar. We're going to walk through kind of the application process. We've had a lot of questions. We wanted to address those, and we'll be going from there. And there is no rush to write down everything. It will be recorded, and we will have this posted on our website as well so that you can find it later or refer back to it. Moving on, it is our duty to let you know that we are funded by HRSA, the Health Resources and Services Administration. And so while this is a HRSA-funded webinar, contents don't necessarily represent the official use of nor an endorsement by HRSA, HHS, or the U.S. government.
So you have Dr. Bree Wetsack and Dr. Nancy Dickey. Bree, why don't you tell them just a little bit about yourself, and then I'll do an introduction of myself.
All right. So my name is Bree, and I am a pharmacist, and I work at Texas A&M, the Rural and Community Health Institute, and I am the co-PI on the Center for Optimizing Rural Health, which HRSA has generously funded. We have some experience with rural work, and I'm really interested and excited to be doing more.
And I'm Nancy Dickey. I'm a family physician. I'm the executive director for the A&M Rural and Community Health Institute, of which the center will be a part. I've been at Archie for several years now and was in the administration of the Health Science Center when Archie was formed. So delighted to be helping stand up the center and hopefully continuing our outreach to those involved in rural health. I think the next slide shows you the agenda of what we're going to be doing. And I'm going to turn it back to Bree to tell us a little bit about the mission of the center.
Perfect. Thank you. So the reason we created the Center for Optimizing Rural Health is essentially to make sure that rural communities retain access to care. We want care to be local. And so HRSA had a call for people who wanted to be technical advisory centers, and that is what the center is. And so we propose to have 3 levels of support, which we will walk through later on in the webinar. The on-site, remote facility assistance, and self-directed. And anyway, there's the need for rural. And so you can see on the next slide what our mission and purpose is. And the need for assistance in rural communities is growing. There are a number of vulnerable hospitals, and there are a number of rural hospitals that have closed. So this is a problem that needs a new solution, and that is why we were here. I'll turn it back to Dr. Dickey to talk about the history of Archie on our next slide.
So the Archie, Rural and Community Health Institute, was created 15 years ago in an effort to have the university work with our colleagues in small towns to find ways to help them keep their practices open, their hospitals open, and to improve the outcomes for the people they cared for. What we found recurrently was that many of the services that people who work in larger facilities take for granted are either stretched very hard to achieve in rural hospitals or may not be present at all. Instead of having a patient safety office with 3 or 4 employees, it might be 1/4 of the job description for one of the administrators at the hospital. Instead of having an office of people in quality improvement, that might be another 1/4 of the job for that same administrator. And so Archie has attempted to create a variety of programs that help small hospitals use innovative technology, adopt programs in collaboration with other hospitals that look like them, and continually keep up with the ever-changing healthcare delivery system. It was that mission and vision of Archie that led us to the outreach to rural hospitals. There are over 2,000 small hospitals in this country. There have been 87 rural hospitals closed since 2010, and there are other hospitals that daily are trying to figure out how to survive in this continuously changing environment of healthcare delivery. I think I would remind us that it is a technical assistance center. We're not a funding center. What we hope to do is create and apply a toolkit that will be created in conjunction with our selected hospitals, but available to hospitals whether or not they were selected as one of the applicants. And so the information available on the center site will change on a regular basis, hopefully ever expanding, and will offer opportunities both the ones who are named partners and those hospitals that apply but are not named partners to be able to continuously evaluate what they're doing. If you flip to the next slide, we have the team that represents the center. This is Nancy Dickey. Dr. Whitback is sitting here with me. Jane Boland is the director of one of the rural research centers from HRSA and will be a co-PI on this grant, helping us with metrics and measurement. Lene Hutchinson is her evaluation manager, and Jane and Lene will be partners with us as we move forward. In the next slide, Tammy Wagner directs the programs that reach out to some 150 facilities across Texas, and will bring her decade or more of experience of outreach to communities in order to help us interface in the most effective manner. Peter Yu is our director of technology and our research scientist. We owe a great-looking website to Peter. Thank you. And he will continuously be involved helping us upload and troubleshoot the toolkit. Cassidy Avila is our outreach and training manager and is the one who helps us with our webinars as well as making sure the information gets out to our dissemination partners so all of you know what's happening here at the center. Robin Arnold and Melissa Garza are our in-house team at Archie and will help make us proceed along the pathway. What we thought we would do for the remainder of the time that we have set forward is kind of walk through the application process and then open it up for questions, see which things any of you may be confused about or that we weren't clear. The application itself is visible on the Center for Optimizing Rural Health website. It will become interactive tomorrow morning when we begin to accept applications. So perhaps the first piece of application information that is very important is who can apply. It's a fascinating answer, even as we have been working with HRSA over the last several weeks. It appears that the definition of rural is somewhat fluid. So let me try to walk you through this, and there's a box on the website that attempts to make it as straightforward as we can. All critical access hospitals, unless you are funded by the Delta Project or the SHRT, S-H-R-T project, are eligible. If you're already funded by Delta or SHRT, then HRSA has determined you are not eligible to participate in the Vulnerable Rural Hospital Program. If you are a PPS hospital and are defined either by the federal site, and the website is on the webinar in front of you right now, or defined by your state as a rural hospital, then you are eligible to apply. It seems that the federal government has a couple of definitions for federal. So if you click on that link or enter that link into your browser, you can answer some questions and determine whether your hospital is considered by the federal government to be rural. But the federal government also recognizes that states have definitions of rural. And so if you're not sure, you can check with your state office of rural health, and they can tell you whether you meet their definition of rural. And then finally, hospitals operated by tribes and tribal organizations under the Indian Self-Determination and Education Assistance Act are also eligible. So if you can check yes to any one of those, you are eligible to apply. Early information from the center indicated that there was a 49 or less bed limit, and HRSA has told us that they are no longer, or at least for this technical advisory center, are not using that definition. So it's federal or state definition, tribal hospitals or critical access hospitals, not bed size, that will determine whether you can apply, hopefully. And remember, if you're already getting Delta or SHIRT. Do note, if you're getting SHIP or Flex money, you're still eligible to apply for this program. So, Bree, I think you're going to walk them through the application.
I will. So, in order to best allocate where the Center for Optimizing Rural Health resources go, we kind of came up with 5 sections to help us select a hospital that would be willing to accept change and a community that could handle the change. And so our 5 sections are readiness to participate, the level of vulnerability, which looks at quality and financial indicators, health of your community, distance to the next or nearest healthcare access, and then partnerships that you may or may not already have. So I hate to read slides, but essentially we're going to read slides. So the first section, readiness to participate, 25 points. And so we're going to look at how does your community leadership perceive the need for your hospital to remain open? Does your community leadership support expanded efforts in the community to address the sustainability of your hospital or access to care concerns? And community leadership could be your
could be your mayor, it could be your city council, it could be your county commissioners. In Texas, we have a number of taxing districts that support local hospitals. It may also be your Rotary, your Lions, your religious organization leadership, or your school district leadership. It is those decision makers who, when they speak, when they call a group together, the community tends to listen. And so your definition of community leadership, you might put in a line or two about who you're calling a community leader, but it is those people that will impact the measure of readiness, if you will.
Perfect. We're also looking at your hospital board. How does your hospital board perceive the need for your hospital to remain open? And the next slide, we ask if your hospital board is actively engaged with your hospital leadership to address the health of your hospital. And is this engagement collegial or not? How do your community members, so this is not leadership, this is members of the community, perceive the need for your hospital to remain open? And what type of information is readily available to your community about the vulnerability of your hospital? And again, we ask these things because we would like to be able to come into a community with a hospital and not have the community be surprised that their hospital is vulnerable. We don't want to be the first indication that change is coming. So on the next slide, we're still looking at community facility level of readiness. We want to know, for hospital administration perspective, the change in your concern for the health of your hospital. Has it decreased a lot, a little, not changed, increased a little, or increased a lot? And we want to know if hospital administration is looking for how to improve the health of your hospital. So just kind of looking at where you are in anticipation.
And outlining some of the activities that you may have already begun to invest in terms of transparency with your community, transparency between the hospital leadership and the providers, and the communications between the hospital leadership, which could be the board or the CEO, and the members of the community.
So on the next slide, we're still at community facility level of readiness. We want to know if your community has made efforts to address the health of your hospital access to care. Some communities we've worked with actually had organizations that came together to ensure that they had primary care or emergency room access. So if you have efforts, are they done in partnership with the hospital? And have you had any miscommunications or incorrect information out there? If you have not had efforts in your community, we just want to know about that. Are you aware of any barriers that might prevent your community from actively engaging? So it could be that there were barriers, or it could be that you're not at that point yet to begin that. On the next slide, this is because this is a 5-year process grant funding opportunity, and we hope to continue it afterwards as well. So we want to know that if you're selected this first year, would you be willing to serve as a mentor to other healthcare facilities in upcoming years so that we can have lessons learned, some peer-to-peer mentoring, and just not lose the knowledge that we gained out of this first year. So that is the first section. The next slide begins our next section, which is level of vulnerability. And again, these are quality financial that you should have on hand. We were trying to keep the application process a reasonable limit. We anticipate 30 minutes to fill out the application because we feel that most hospital CEOs would have this information readily to hand. So we're looking at quality, your 30-day readmission rate, fall rate, medication error rate, patient willingness to recommend. The operations, we're looking at your admissions, average daily census, average length of stay, finance, your total margin, net revenue, debt to capitalization, and accounts receivable days. We were looking at the previous fiscal year. So on the next slide, we kind of move into the health of the community. So it's not just the health of your hospital, but looking at the health of your community. And so we start off with demographics. One, so we can find you and reach out to you. So we want to know the name of your hospital and your name and position and contact information for the person doing the application. And then we're looking to have diversity in that we can only help a number of on-site hospitals each year. And so vulnerability is different. So there's different ways in which a hospital or a community could lack access to care. And so what we would like to do is have a diverse group. And that's why we're asking about if you're critical access or prospective payment system, are you part of the system? Because we hope that by working with different communities, we're putting the knowledge that we learn on our website available to everyone so that somebody who's the same vulnerable as you are can learn from what we've walked you through, since we can't select every hospital. So that's kind of what we're doing. And also asking about if you're part of a system, that question is, you may be willing and your community may be willing for change, but if you're part of a system, then that's a conversation we need to have with the system to see if change is amenable. So we're looking at your service lines, the size of the community, your geographic size, the catchment area. And the next slide, we continue with health of the community, looking at your status. If you've had a population growth or loss, the average age of your population, average income, your payer mix, if you have industry coming or going. And then another way to look at the growth of a community is local school enrollments over the last decade. The next slide looks at distance to access to care. So worst case, if your hospital weren't there, where are the next 3 facilities of similar or larger size? And how far is that distance? And have you had any experience in partnering with these? Have you all banded together to ensure that there is access to care? And then are you tracking where your patients go for what services they leave town? And this brings us back to the service line conversation and maintaining that care locally and make that the care that's retained locally is the best fit for your community based on what they need. And finally, we look at partnerships. So we want to know, are there local organizations or coalitions that deal with access to healthcare issues? Is somebody else already working on this that we can partner with instead of starting from scratch? Are there local individuals or organizations that could be enlisted to provide support? So maybe they haven't gotten on board yet because they didn't know, but are there people we could work with in your community to add synergy to our efforts? And then what work have you done or are in discussions to with philanthropic funders? And this just kind of indicates the willingness of your community to partner.
It's also an indication, again, of the level of commitment that the community says we got to find an answer to keep these doors open. And so we're kind of pulling out all the stops in terms of sources of assistance. So Many of those questions will require some data entry. A lot of them are a bit subjective, and we recognize that. That's probably one of the reasons there are a fair number of questions, because if you answer even subjective questions, eventually a pattern kind of begins to come through. The good news is again, we estimate 30 to 45 minutes to fill this out. We borrowed the questions from a variety of tools, each of which tended to be 60 to 90 minutes. We decided we couldn't ask hundreds of questions. So we're hoping this gives us a picture. Once we get the applications, and you'll hear this repeatedly, so tomorrow morning, the application will go live. That means you can access it on the website and begin to fill it out. I believe you can see the application today. It's just not interactive until tomorrow. The application period will remain open until November 30th, close of business. And then we will spend the month of December trying to get a feel for the applicants and the diversity that's there. We will select 30 different hospitals. Tier 1, intensive on-site technical assistance. There'll be 3 tiers: Tier 1, Tier 2, Tier 3. So let's talk about each one of those. Tier 1, intensive on-site technical assistance. We're going to select 5 hospitals. We'll have subject matter experts as well as members of the center team that go on-site, get to know the community, get to actually dig a little deeper into some of the data that defines who the hospital and the community are, and look at what activities have already been attempted in order to help create a toolkit for that particular community in terms of needs, resources, and strategies to try to keep their facility open. And there will be 1 or more visits to the sites, and of course a great deal of virtual communication in between. This is the highest level of technical support and will be repeated each year. So 5 communities, 5 hospitals will be chosen in 2018, 5 in 2019, 5 in 2020, et cetera. Tier 2 is remotely facilitated technical assistance. We'll select at least 25 communities where they will have significant facilitated intervention, but it will be virtual intervention. Educational materials, webinars, peer-to-peer learning conversations. We're leaning in the direction of creating learning groups among the 25. So you would be paired up, again, virtually with other facilities to share not only the recommendations being made for your facility, but also to talk to other people who are sitting in very similar situations to yours, and oftentimes may look at a set of data or a set of recommendations through a slightly different looking glass. This group can request one-on-one topical technical assistance. You have a particular issue with out-migration, or you're about to lose your only anesthesiologist. So we can talk about one-on-one issues in addition to the group activities. And while we hope that the facilitated assistance moves a facility along the pathway from vulnerability to stability, if you were selected as a level 2, you could apply in subsequent years for a level 1 if you felt like that would enhance your progress. Tier 3 is essentially making the site and the toolkit available to all those who applied but didn't happen to be selected in the first 30 facilities. The toolkits will be made publicly available on the center website, and obviously that will be a continuously moving target. We have some parts of the toolkit that will go up even during the application period, but some of those pieces of the toolkit will be developed in partnership with the facilities and communities with whom we're working. There will be resources. First one will, of course, be this webinar that'll be archived there, and people you talk to who said, "Oh, I didn't get a chance," can go to the center website and listen to the webinar. There will be documented best practices and a library. We'll try to make sure we don't simply inundate you with long, pithy articles, but rather hopefully some documented best practices. And there will be the opportunity to schedule some one-on-one technical assistance, even for the Tier 3 facilities. But the reality is that the level of funding simply won't allow 2,000 facilities to have extensive one-on-one interventions. The communities assigned to level 3 can certainly apply in subsequent years for consideration of a higher level of intervention. And again, hopefully will find themselves further down the road of what do we do next from simply participating at the self-directed level. I think it's important to repeat a little bit of what Bree mentioned.
Our next steps.
But part of that is that, there's not a grade at the end of this. We're going to collect points as outlined in the application, but we are looking for geographic diversity. We're looking for diversity. That is, we hope there will be both critical access and PPS hospitals. We hope there will be some diversity between very small hospitals and those hospitals that may be at the upper sizes of rural. The hospitals that are already anticipating or have been notified that closure is imminent will have a tougher row to hoe. The reality is that if they've already been notified they're going to close in the next 60 days, we won't even be through the application selection process in time to be of significant assistance. Although those facilities may find some use in the toolkit that's being built during the application process. The application is open from tomorrow morning, October 30th to November 30th, 2018. We will spend the month of December sorting through the applications, and HRSA will have some input into the selection criteria. The level 1, the boots on the ground facilities, will be notified in early to mid-January, and the level 2 and 3 applicants will be notified by the end of February. Again, the toolkit will be under continuous development even before the notifications are made, and so hopefully the facilities who are applying can continue their forward motion. The center team will be at a variety of conferences that you may already be planning to attend. We'll be at the American Hospital Association Rural Health Leadership Conference in Phoenix in early February. We'll be at the American Hospital Association annual membership meeting in Washington, D.C. In early April, and at the National Rural Health Association annual meeting in Atlanta the second week of May. If you're planning to attend any of those, we certainly hope you'll come by and see us at the booth or catch us in the hallways and give us any input or suggestions or ask questions for that matter. The center website, I didn't see it on here. Mm-hmm. Yes. Okay. So the center website is up and actionable. The application will go live tomorrow morning. And we hope that when we finish the webinar this afternoon, you'll take just a minute, actually it says 5 minutes, and go to the Qualtrics survey that's there. Tell us which things we left confusing in your mind, which things you wish you'd heard that we didn't include, and any other feedback about today's webinar that we intend to facilitate your application process. Bree, what did I forget to go over?
Well, just in case you can't look back on the slides quite yet, the website is http://optimizingruralhealth.org. And for those who joined the call late, I saw we had some questions that come in. So this is not a grant. You are applying for technical assistance. There are no funds to be given to vulnerable rural hospitals from this. We will contract with subject matter experts and help you maintain care locally. That is our goal, to provide technical assistance. So there's no funding level. And that's it. We're a Center for Technical Assistance. So that was just in case you joined the call late.
All right, so give us that website one more time, slower, Bree.
It is optimizing.ruralhealth.org.
Okay. Do we have an opportunity for questions? I think, Cassidy, if we unmute our participants, they can indicate they have questions verbally.
Sure. Would you like to unmute everyone and they'll just ask questions, or would you like them to use the chat feature?
Well, it would be less crazy if we use the chat format, if everybody's able to do that.
I have the chat box up now.
Okay, so
okay.
They have the option to chat to me, Cassidy, or to you, Bree. So just know you may get some and I may get some.
Okay. Okay, so we attempted to answer the question, am I missing something? What is this grant? The program is technical assistance and virtual or on-site assistance looking at a vulnerable small hospital and things that hospital and or its community might be able to do to move it into a stronger fiscal position. That can be everything from reevaluating your service lines to improving your coding to recommendations for adding services like telemedicine or partnering with a nearby hospital to share specialty care and decrease the outmigration from your community. So it's not us evaluating grant opportunities to hospitals, but rather it is a grant funding us to assist the hospitals. Ashley, you got other questions there?
It looks like we have a couple of questions about making the slides available. And we will be sending an email out with the survey link after this webinar is over. We'll also send a link to our website. And it's not really a 5-minute survey. It truly is more like a minute. It's 5 questions. So we'll make all of that available.
So you're gonna send these slides to everybody who registered, and they will be available this afternoon and going forward on the Center for Optimizing Rural Health website. Correct?
Correct. And then we do have a couple of questions. Is there funding available from level 1? Oh, I'm sorry, I just lost it. 1 second, we'll get it back. Is there funding available from level 1 to hospitals that will enable us to facilitate and implement the local action plans or suggested changes? And I think you've already answered that.
Yeah, there is no funding available, although one of the pieces of the toolkit may be helping facilities identify and make strong proposals to philanthropic groups. We feel pretty strongly that philanthropy probably should not be trying to fund making your payroll for the end of the month. On the other hand, if you can put together a business plan for a service line that will bring additional patients into your facility, approaching a philanthropic organization to give you the startup funds makes a lot of sense, both for the philanthropy and for the facility. So helping you identify sources of funds for some of the implementation steps may well be part of the toolkit, but actually having funds for those is not part of the HRSA technical assistance program.
Thank you. And we also had a question, where on the site is the application, and I'll send that link out. The next question, would CORA entertain a single application from 4 eligible rural hospitals within a single region?
Yes, actually we would. We think that the opportunity for a number of small facilities in a region to come together and maximize your collaborations. So whether that is sharing specialty services or one of you becoming expert at obstetrics while another one does more of the trauma care, we think it makes a lot of sense to try to create those collaborations. If we continue to do the business that we see regularly in Texas, which is 3 to 5 facilities competing with one another, we think the end game will be that all of them will probably end up closed because there isn't enough business to keep the doors open unless you find ways to capitalize on your shared competencies.
Okay, and the next question, can the hospital be for profit or does it have to be not for profit?
It has to be rural.
I don't think there's anything in either the federal or the state definitions that say profit or nonprofit. I think there are even some for-profit critical access hospitals. So the funding source for the hospital is not the deciding factor. It is your being recognized by the federal government or the state as a rural facility, and that usually has to do with number of beds and distance to other sites of care.
Great. And next question, will this help in radio communication?
Will it help in radio?
Correct. Radio communication. So if, Scott, if you'll expand on that question, maybe we could answer it a little better. But for now, I'll move on to the next question. If we're applying for SHRT grant, can we still apply for this grant?
If you're just applying, it is my understanding you could apply for both, but being selected for one or the other would then bump you out of the queue. So you might, because HRSA wants to have some role in facility selection, you might indicate on your application that you are applying for 2 programs. What we wouldn't want is for an application for 2 programs to bump you out of both programs. And so HRSA might lean on one or the other of us to give you an early enough answer so that you could put your attention there. So I think as long as you have not already been accepted into and a part of funding for SHRT, that an application for both programs should not bump you out of either program. And if whoever asked that, Cassidy, if we can kind of star that, actually there will be some frequently asked questions attached to this webinar, and I will double check that answer with HRSA since they were changing the definition of rural as late as this morning. Let me double check that, but I'm pretty sure that's the correct answer.
And the Center for Optimizing Rural Health is going to do the selection based upon the applications, and HRSA, as part of this cooperative agreement, will do due diligence to ensure that the selected facilities meet the definition of rural as stated, and that they are not currently being funded by the Delta Project or the Small Rural Hospital Transitions Project. So there will be a double check.
Great. And then I think we got some clarification or elaboration on that other question about radio communication. So the revised question is, when rural EMS that is hospital-based and need for increasing communications, can this grant help?
Okay, again, this is not a grant. What we might be able to do is share some best practices utilized by other rural facilities that run their own EMS, or help put together a request for a state or philanthropic organization to fund a step up in terms of the quality of communications. Actually, fully utilizing the rural EMS and making sure that there is best practices in terms of where you locate those resources is very often a key player in rural healthcare delivery. So if there's a problem with radio communication and how to increase that, I would think that would be something we'd be happy to look at and make recommendations. In fact, there are a number of rural places that use telemedicine on the ambulance transport in order to facilitate rapid intervention even during transport.
Thank you. And we don't have any questions, any additional questions at this time.
I don't have any others that came through. Okay, well, on the website, there is an email, and the email is working. They're being received and read and responded to. So if you don't have a question right now, but you think of it as soon as you walk away, feel free to email, and we will get back to you the best that we can.
And again, let me repeat that the toolkits, the lessons learned, the best practices will in fact be resourced on the center's webpage.
Yeah.
So if for some reason your facility chooses not to apply, you can still regularly update what's happening at the center by going to the webpage and looking at information. The information is likely to be in buckets. So telemedicine is a tool often used by isolated rural areas, and there will be a number of things there. The information about how to address maximizing income, so coding information, and some negotiating with private payers might have a variety of different sorts of information in that bucket of the toolkit. So while we hope that we'll get a variety and a significant number of applications, we would encourage all of you who have enough interest to join the webinar to regularly check in on the website and see if there's additional information that might be of use to you. The challenges to rural healthcare are not likely to go away. The ever-increasing technology of medicine paired with the ever-increasing desire to reduce the cost of healthcare mean that our smaller facilities are going to continuously be in a crucible. And the solutions that worked 5 years ago may not be working today, and the ones we come up with in the next 2 or 3 years may have to be modified 5 years from now. So if you're in a small rural facility, we appreciate the service you render to the population that lives there and hope that we can help you continue to meet the requirements, the needs, the desires of the population that you serve. But it's likely that the tools that we use to do that will be almost as continuously changing as the technology that drives healthcare in general.
Dr. Dickey, we got another question. Could this program help us to identify if our billing could be improved or if our charge master could be streamlined?
Yes.
Great.
Certainly, one of the things that has appeared regularly as an issue for small rural hospitals is whether they are in fact using their charge master, their coders, to the maximum benefit, and it has been very interesting as you bring in new processes and sometimes new people to discover that doing the same thing you've been doing, but actually coding it in the proper fashion can generate a significant change in your revenues. We could wish the answer for any one of you is kind of a one-stop shop that we fix your coding and you take care of the problem. The reality is most places we've been, it's a multi-tiered intervention, and going back to Bree's early slides about community engagement, requires the energy and enthusiasm of community leadership as well as hospital leadership in order to assure a healthy facility. But we also believe that you shouldn't have to leave your community and go substantial distances in order to access quality health care. So we look forward to working with many of you and making information available to all of you. As Bree said, there's an email available on the website, and we're responding to that daily, and the applications will open in the morning.
Cassidy, I don't have any new questions. Do you?
No questions at this time.
Thank you, everyone, for signing on. We look forward to the next few months.